Hello, everyone. Warm greetings to all the delegates who joined us on day 2 of this 1 week faculty development program that is being organized by Chevrolu Hanmaya Institute of Pharmaceutical Sciences. On behalf of our institute, I wholeheartedly welcome the speaker of today's session, Dr. Sonal Sekhar, on behalf of our institute. Sir, are you there, sir?
Hello, yeah, I'm there. Yeah, I can hear.
Okay, sir. Thank you, sir. We once again thank you for accepting our invitation and being the speaker for today's session.
Thank you,
Now,
thank
I
you.
hand over the platform to you so that you can present your screen and then continue with your session, sir.
Yeah, sure. Can you guys can see my slide? Hello.
Yes, sir.
Can you guys can see my slide?
Yes, sir. Your screen is visible, sir.
Visible now. Okay, okay. Yeah. Good morning, everyone. So, topic of my before starting, I want to tell the thank you to the management of Chevrolu Hanmaya Institute of Pharmaceutical Sciences and Principal Dr. Vidyadhara and Dr. Valluri and his team for organizing this FDP. So, the topic of my presentation is from hurdle to highlights, navigating the pharmacy practice research. So the coming 45 minutes, I want to talk about what is research, why do you want to do the research, and what are the different types of research. So when I am talking about the type of research, it is nothing to do with the traditional type of research. What I'm going to talk is actually outcome-based type of research. Then how to develop a research of research findings, and what is after once you complete your research. So what after that you can do. Then finally, what are the different challenges when you will face when you are doing the research. So all these are actually my own experience. I think most of the people who are attending is a faculty. So each one have, it may not be a new idea, but here what I'm trying to say, all these things are actually my own experience about the research. I want to start my presentation with one of the famous quote by Werner von Braun. So he's a German American aeronautical engineer. So he have told that research is what I am doing when I don't want to know. I don't know what I am doing. So it's very self-explanatory. We will do the research and find out the new things. When we don't know the things, we have to do the research and find the solution for that. So I will start the definition of research that I have taken from the Cambridge dictionary. Cambridge dictionary. So research is nothing but a detailed study of subject, especially in order to discover new information or reach a new understanding. So this also the very common definition of the research, either to discover new things or advancement of the new knowledge, like a new understanding about the subject. For that, we are doing the research. So why do you want to do the research? So it is a purely personalized thing. Okay, for why it is called personalized thing? So being a faculty, your purpose of doing the research will be totally different from the student perspective. For example, students, you can see that like there's the project certificate itself, you can see partial fulfillment of their whatever the farm T or farm project. But as being a faculty, so you will be a guide, and you have the different purpose, like either for advancement of your career, like a promotion purpose, or you can see that sometimes it will be a passion to do the research. Okay, so the purpose of the research it will be highly personalized. So different level, it will be different. So earlier I have mentioned about the type of research. So this is not a traditional classification of the research. So here you can see that there are some research are novelty research, some are utility research. If you see, majority of these pharmacy practice research are coming under the category of utility research. Okay, novelty research means normally you can see if you do you are finding out a new formulation. Okay, that is an example for the novelty kind of research. Okay, similar way you are discovering a new molecule or new drug, that also falling under novelty. But as the utility kind of research, it has a direct application in the clinical setting. For example, your hospital have antibiogram, that means cumulative antimicrobial susceptibility pattern or resistant pattern. So your hospital management or one particular department, for example, general medicine, they want to update the antibiogram. Okay, so normally the hospital they have who have developed the antibiogram, every 6 months they will update that. So you are for that you have to do the data collection and do the research. Okay, you have to collect the current antimicrobial susceptibility pattern to what we can say revise your antibiogram. So that is a kind of utility research. It may not be novel, but it has a direct application when you are looking into the to the factor. So it has a direct application in the clinical management or patient care. So such studies are called utility research. So one we cannot say that one is good than other. So that is a context it will define whether you have to go for the novelty research or utility. Next one is how to develop a research question. So you can see that there are being a faculty, you have different method to develop the research questions. So here purely what I will do when the students, for example, I want to give a Farm D project or M-Farm project. So for example, we have a load system here for the students to select the research guide. So what we will do, the students first, instead of load system, we are following another method. So normally earlier we are using the load system. Now we have changed the system. Load means the by chance students are getting the faculty. So here we will conduct a test for, we will already give the syllabus. Okay, for example, we will do the guide selection usually for the Farm D usually in the 4th year itself, end of the 4th year. So we will conduct some multiple choice questions, what they have studied the same year. Then we will rank the students based upon these multiple choice questions. So the first student who have ranked first, he have the choice of selecting the faculty first. So each faculty is the profile, the key research area they will display. So based upon the student's interest, based upon the ranking, they will get, if it is a first rank student, he will get the first choice too. So each faculty will make a fixed, okay, around 3 to 4 students only, maximum one faculty. The students can choose for one faculty. Okay, then the 4 is completed. If they that faculty will be removed from the list. So like that, based upon the ranking, students can choose. So once a group of students has chosen me, for example, Farm D, once they approach me for the project, so I will not directly give the topic to them. So what I will tell them, you go and read the various literatures. So especially the very reputed medical journals like BMJ or the Lancet. So why I will suggest for them, because they can read, they can start reading the one is actually their habit of reading the journal will increase. At least they can initiate that one. So then it will tell you that which are the current focus of the research. Currently, what are the major focus of the research community, global research community? What is the major focus? Okay, that also we can get from the if you read the very reputed journals like BMJ and Lancet. Then the most of these journal have the very standard method of writing the thesis. I mean, writing the articles and publications. So they can really see that how to write and how to write the result, how to write the discussion, all these things, they will get the idea. So the purpose of the literature research is find out what are the key area the research community is focusing. Then second method is actually the fourth year family, our students already exposed to the clinic. So they know that some of the clinical diseases, they maybe got interested some of the diseases. So I will tell them that, okay, during your clinical exposure time, did you see any interesting cases? Or another thing, either from the students, sometimes our own clinical doctors, like for example, the clinician or infectious disease specialist or endocrinologist, sometimes they will approach our department. If I have rapport with some of the doctors, they will approach us and tell that we have interested to do this particular study. So I have already mentioned that first I will tell the students to do the literature search. Okay, then come up with some of the topic they are interested. List out the some of the topic, and then we can discuss. Okay, most of the time what will happen, the students will be interested to one study, and but that drug may not be launched in India or it may not be available in our hospital. So that point, it is not feasible to do that particular study. So I will tell them to, we will discuss like whether it is feasible or not. In case it is nothing is going to work, then what I will tell that, okay, there is the second method, clinical experience by. So doctors, suppose any doctor is actually approach us, I will tell them that, okay, this endocrinologist or ID physician have told that we can do this particular study. So if you are interested, we can you can work on this topic. So that's what I'm telling. These are the two topics. The way we will start developing the research question. So coming straight, what I'm going to say is actually some classical example how we have developed the research question by using these two methods, literature search as well as through the clinical experience. So first I am going to discuss about some of the research topic or research questions we have derived through the literature search. So this was actually one very interesting topic published in 2014 in a journal called Science Translational Medicine. Okay, so the topic is the metformin as an adjunct anti-tubercular therapy. So all of us know that metformin is according to American Diabetic Association, metformin is a first-line drug of choice for the management of type 2 diabetes. But okay, so far until that, it was not used for, it is not a standard therapy for the management of TB, right? But when you look into the why it is actually, what kind of mechanism and what are the possibility of conducting this study, we have seen that, okay, we cannot do a trial because no doctors will prescribe. Okay, academic level for PharmD project, we cannot do the trial because no physician will agree to prescribe metformin for the TB. So it is not at all possible. So when you read this article, we have found that the metformin used as a adjunct treatment along with the anti-TB medication, ATT therapy. So metformin also used as adjunct therapy. Okay, in this was a report of both preclinical studies, cell line studies, as well as they have conducted small set of the patient population also. Clinical and preclinical data was available in this article about the metformin effect against the TB, Mycobacterium tuberculosis. So then we have started reading about this mechanism, how it is actually work against the TB. So so they are clearly explain about what are the problem with existing anti-TB medication. Current therapy, what they are saying, current therapy, that is ATT therapy, is mainly focused on pathogen target therapy. That means it is actually killing the pathogen. But the pathogen targeted therapy, the problem is that the development of resistance and ATT have very severe adverse effect, including not just nausea and vomiting, tiredness, all these things are, and even the liver enzymes will get elevated. The adherence is very, very poor for the ATT therapy. So what metformin, what they are claiming, metformin is a AMPK activator. You can see already that the adenosine monophosphate activated phosphokinase, KMPK activator. So what it will do? It will increase the immunity of the host. So it is considered as a host targeted therapy rather than the conventional therapy that is focusing on the pathogen targeted therapy. So metformin will increase the immunity of the host and it will inhibit the growth of the Mycobacterium tuberculosis. Not only that, it will potentiate some of the anti-TB medication also. Through that, it will culminate the Mycobacterium tuberculosis. So that's what the article claiming that mechanism. So we thought that why can't we do this study, but we cannot do a direct study by using the metformin for TB patients. So we need a population that is already using the metformin, obviously type 2 diabetes patients. So when we look into the literature of diabetes patient and TB connection, we have seen that there's a more than 15% of diabetes are actually tuberculosis. Not only that, the literature is also saying that the tuberculosis is also attributing for the diabetes also. There is it is like a bi-directional relation between the TB and diabetes. So we thought that, okay, it is a good population. If you take the type 2 diabetes patients who have the metformin, obviously the first line choice. So we can initiate this study. So we conducted this study, okay, but in a different direction. Previous study, it was like a treatment for the TB. So we thought that why can't we use as a protective? Why it is a preventive therapy, like a protective effect of metformin against the tuberculosis infection in diabetic patients. So it is a PharmD project. So we have thought to do a retrospective study because the prospective study is very difficult because we don't know if you go for a prospective cohort study after getting the metformin for diabetes patient, we have to wait for till the TB is developing. There is no chance to, sometimes it will not develop also. So we thought that for the feasibility to finish the study within 1 year of time, so we thought that we'll go for a case control study. So here case is the diabetes patient with TB, tuberculosis, diabetes patient who have developed the tuberculosis. That was our case. Okay, control is the diabetic patient. Then we have looked into their exposure status. How many of them, both case, how many of them receive the metformin, how many not receive the metformin. Okay, similar way, control, how many of them receive the metformin, how many of them not receive the metformin. Okay. So we saw that the patient who have received the metformin can have the less number of tuberculosis. In that means case, we have seen that way. Okay, you can see that. So finally, we have calculated the odds ratio. So odds ratio came somewhere around 0.257. Okay, odds ratio will tell the risk. Okay, so here it is a less than 1, so it will tell you the protective factor. So to quantify that, what we have done, 1 by odds ratio we have calculated. So 1 by odds ratio came exactly 3.9. That means roughly, so 1 by odds ratio is a protective effect. So we got in this study we got a 1 by odds ratio 3.9. So roughly it is, if you are rounding, is a 4. So we can say that the metformin have a 4 times protective effect against the tuberculosis, okay, in the compared to non-metformin patient. So that means that those who are receiving the metformin, they have 4 times protection against the development of tuberculosis compared to those who are not on the metformin. Okay, this was our result. So you can see that these are actually PharmD students. So this study was published in the Brazilian Journal of Infectious Disease in the 2017. So this is a classical example from the literature. We have taken a concept and we have modified the concept to suit our settings. Another one, you can see same year, 2014 itself, we have seen that higher potency statin and risk of development of new diabetes. So this literature, this study was conducted, it was published in the BMJ. Okay, what was the concept of this study? the statin, you can see that the statin can be classified based upon the intensity. Okay, that intensity is based upon how much percentage of reduction the different statins will do on the LDL cholesterol. Based upon the statin potency, how we can classify high potency, moderate potency, and low potency statin. Okay, for example, we have the atorvastatin and rosuvastatin. These two are the very commonly used statin in our population. So atorvastatin and rosuvastatin have its potency is starting from moderate to high. Okay, if you see atorvastatin around 10 to 20 mg, 10 to 20 mg, it is a moderate potency statin. Whereas 40 and 80 mg is considered as a high potency statin. Whereas rosuvastatin 5 to 10 mg is a moderate potency. Okay, 20 to 40 is a high potency statin. Other statin like pitavastatin, simvastatin, pravastatin, fluvastatin, all these have low potency to moderate potency. Except atorvastatin and rosuvastatin, all other statin does not have high potency statin. So you can see that what this article is saying, a high potency statin have the high risk of getting a new onset of diabetes. Until this, before this article, what we have thought, okay, statin is normally used for the people who have high risk of diabetes, high risk of cardiovascular disorder because of its pleiotropic effect. Okay, pleiotropic effect means atherosclerotic, other than the lipid lowering action of the statin is called pleiotropic effect. For example, the statin can cause statin have the anti-inflammatory action, antioxidant action, atherosclerotic plaque stabilization action, and thrombotic. It will inhibit the thrombotic forces. All these effects are called the pleiotropic effects. Because of that, statin should be given for the people who have multiple risk of cardiovascular disorder, including the diabetes. But 2014, this BMJ article saying that high potency statin, if you took, it can cause the risk of new onset of diabetes, because what they are claiming, the statin will inhibit the various insulin signaling pathways. Okay. Apart from that, it will inhibit the influx of calcium into islets of cells, okay, where the insulin is produced. So that because of that, it can lead to the hyperglycemia. So we thought that why can't we do this study in a different way? Because this study is conducted in the Caucasian population. They have done the study in the UK and Canada. So they have clearly mentioned that the population involved for this study is Caucasians. So we thought that why can't we develop a new concept out of this? So we thought we know already that the South Asian population, India is also coming under the South Asia. We have already multiple risk of getting the diabetes. Okay, so because we have our genotype is totally peculiar. So if you see our population, we already have multiple risk factors. Like you can see that in our diabetes people, even the lean people are getting. Western concept it is obese people. But in our population, type 2 diabetes even occurring at those who are lean people, low BMI, and we have the low risk of low threshold for getting the diabetic risk. Okay, we have easily we will get the diabetes because we have low threshold for the diabetes risk. So since our population have the multiple risk factor, so no need of giving the high potency statin. Even low potency statin can also, that was our idea. Low potency statin can also cause the new onset of diabetes. So we come up with an idea that is called South Asian population have as a higher likelihood for the diabetes risk for the statin, regardless of its potency. That means even the low potency and moderate potency and even high potency, all these potencies, regardless of that, South Asians have high risk of getting the statin-induced diabetes. So if you have a very good idea, okay, you can even publish in the journal. Okay, there are different journals. Idea we can publish. That one of the journal is medical hypothesis. We have published this concept in the medical hypothesis. So another thing is actually, you can see here the cholecalciferol. Okay, cholecalciferol earlier the concept was vitamin D. Okay, that is a vitamin D. So it is an antimicrobial. There are when we look into the various literatures, we saw that the vitamin D have the antimicrobial action. Okay, direct antimicrobial action. So then at the same time, we have seen some of the literature, it does not have also. So there are contradictory statements or results are by the different article that cholecalciferol have the direct action and direct antimicrobial action. So we thought that since there is a the contradictory results, okay, why can't we do one study and prove that whether it really have the a direct antimicrobial action. So when we have, so for that we used the cholecalciferol and two microbial kits, Staphylococcus aureus and Escherichia coli. So we done an in vitro study and we have calculated MIC and minimum bactericidal concentration. So what we found that the cholecalciferol will not directly inhibit or kill the organism. All this, but the we have done even one in vitro study. So in that we have seen diabetic foot ulcer we have done. So it is promoting the wound healing and it is reducing the wound infection. So what mechanism that it does not have direct action, but when you are taken orally or injectable, it will increase your immunity. It will promote. You can see that the BDR gene. Okay, so it will be promote the production of antimicrobial peptide like LL37, cathelicidin. So through that, it will act in the promoting your immunity, and through that, it have the antimicrobial action. But there is no direct antimicrobial action. That was our result. So till now, what I have told is actually from the literature, we have got the idea. And based upon that, we have conducted the study. Okay, so the research questions we have developed and we conducted study. But the study, what I'm going to talk now, it is actually from the clinical experience. One of the ID physician, current, the head of the infectious disease department of Kasturba Medical College. So he has approached us and told that. So I have seen that after giving the cefepime, there is a fourth generation cephalosporin. So a lot of patients are getting neurotoxic adverse drug reaction, disorientation. Few patients seizure develop. Some patients you can see altered sensorium. So that kind of effect I have observed. So why can't we do such study? Okay, so I thought that coming back, okay, if they are not getting their own idea, so I thought that okay, if they are come up with any difficulty, so we can give this topic. So finally, the same thing happened. One of the students told that they are not able to find out their own topic. So I have just given this topic. So what was this study? Is FEP-induced neurotoxicity. So since it's a PharmD students, because prospective, always giving the prospective study is a little challenge because the time constraint and even if they didn't get the outcome, if outcome is very short, there is no problem. Sometimes the outcome development will take long time. So then it is not feasible to do a prospective study, especially PharmD students. Okay, so then we have thought that anyhow, this study can be if you do the prospective or retrospective, there is no result is not going to change. Only if you go for retrospective study, it is more feasible and time consumption we can reduce. So we thought that we will conduct this study as a retrospective cohort study. Okay, so we thought we have developed two cohort retrospective way. So those who receive the cefepime, so they are considered as a study cohort, and those who are receive the other antibiotic, okay, they are considered as a reference cohort. So study cohort is a cefepime group, and other antibiotic group, those who receive the other antibiotic, they are actually reference cohort. Then we have followed them retrospectively and see that whether they have developed any kind of the neurological adverse drug reaction, such as already I told seizure, altered sensorium, loss of consciousness. Okay, all these are actually disorientation. All these are actually neurological toxicity. So we have seen that we have calculated odds ratio and find out that it was somewhere around 2.5. That means the patients who are receiving the cefepime have around more than 2 times higher chances of getting the neurological toxicity. Apart from that, we have calculated number needed to harm. NNH will call number needed to harm, because if the outcome, it is a negative outcome, neurotoxicity, right? So it is a negative outcome. So we will calculate the number needed to harm. Instead of that, if the outcome, for example, outcome is reduction of mortality. So reduction of the mortality is a positive outcome. So that case, instead of number needed to harm, we will calculate the number needed to treat. So since the outcome is negative, for this study, we calculated number needed to harm. So number needed to harm is nothing but, okay, 1 by the reciprocal, or 1 by absolute risk increase, 1 by ARI. Okay, that is called the absolute risk increase. That is called the number needed to harm. How we can calculate ARI? So even rate in the exposed group minus even rate in the control group. Okay, so that will give you ARI, absolute risk increase. I will repeat: absolute risk increase is equal to, okay, even rate in the control, even rate in the exposed group minus even rate in the control group. So we got ARI. So 1 by ARI, that will give number needed to harm. So we calculated this study. So we got the number needed to harm 17. Okay, that means if 17 patients are treated with cefepime, 1 person will develop the neurotoxicity. Okay. Another way, if you say, to develop one case of neurotoxicity, 17 patient has to treated with cefepime. Okay, that is called the number needed to harm. So that's what we have calculated that, and finally we have got we were able to publish this study in the current drug safety. This was actually an example for how to develop the research question from the we already told literature search as well as from the clinical experience. Now, most of the time for the pharmacy practice research, we will be focusing the study mainly in the hospital setting. Very rarely we will do the community-based study, because community-based study, most of the time people will think that it's a survey study, right? So whenever you do the community-based study, it will be you have to develop the questionnaire and you will do the survey. Okay, for example, if you want to do a study about over-the-counter antibiotic dispensing in a community pharmacy, what do you do? So you will develop the questions and go to the pharmacy and ask the pharmacist that whether you are giving the antibiotic over the counter. Okay, what answer you will get? Obviously, they will tell that no, right? So the problem with these survey studies, actually, the inherence of the bias. Okay, there is a part of the survey studies. There is inherence of the bias. So already, okay, for example, there are different bias. Self-reporting bias, like already the reason I have told that pharmacist, okay, in the fear of that some regulatory consequence, they will tell that we are not giving the antibiotic over the counter without prescription only. In our pharmacy, they will give. But actual scenario is totally different, right? When you go to the pharmacy and ask, you may be yourself experience that you are getting the antibiotic over the counter. Okay. Another problem with these survey studies are actually one is actually self-reported bias and recall bias. Next one, recall bias means your response is based upon the most of the time recall. If your questionnaire contains that last 3 months or last 6 months, whether you are actually given any critical care antibiotic, so that to think it is not from the they are actually collecting from the record. They are recalling and telling that, not collecting from the record, right? So there is a recall bias chance is high. Apart from that, there is inability to verify the actual practice. That is another problem, because you can see that here the answers are reflected. Okay, most of the from the what the pharmacist is telling. not from the, you are not observing actual practice, okay, how it is going to. So there is no room for the verification. What are the pharmacists telling? You are believing, right? Yeah, I'm not. You don't have any other option. You have to believe. When you are filling the questionnaire, you have the pharmacist telling, "No, I'm not giving." So yet there is no room for actually verification. But actually, there is a gap in the what respondents say and what respondent actually doing. Okay, previously I had told that, okay, they will tell that I'm not giving over the counter when you're when they say surveyor. But actually, if you went for the as a customer, obviously they will give the antibiotic over the counter. So there is a gap in the respondents what they say and what they actually do. Okay, these all are actually the what we can say the drawback of survey studies. So there is a one-stop solution for that. That is called the standardized patient method or SP method. Okay, so what is SP method? You can see that it is called simulated patient or simulated participants. Okay, so SPs are independent specialists trained to portray patient scenario. So they'll be trained to act like a patient. Okay. This concept was introduced in the medical education, the SSIP, standardized patient method. So it was introduced in a medical education in the early 1960s. So as the name implies, you can see that SPs are offering standardized controlled experience for the learners. So the beauty of these sections are, unlike peer role play, you can see the image here, peer role play, or the usage of factor who have not received a formal SP training. These sections are actually reproducible and measurable. We can repeat this section and measure again also. So that's the beauty of standardization method. So SPs are rigorously trained to maintain a consistent and highly realistic portrayal. So they are also prepared extensively to give the feedback to the trainees on their communication and interpersonal skills, and in many cases to complete the scoring checklist. So SP simulation involves the use of individual. They are trained to portray either role of the patient or family members like bystanders or others to allow the students to practice physical examination skill, history taking skill, and communication skill, and even other exercise. So instead of directly going and do the experiment on the a real patient, so they can get trained in the case, the similar scenario we are simulated, the scenario we are creating, and the students are well occupied for taking the patient case history and physical examination on DSPs. Later on that, once they develop that skill, they can directly involve in the patient care. So SPs have used to assess the quality of care in India and even other low and middle income countries. For an example, you can see that the SP studies have shown that in India, private retail pharmacies are source of non-prescription antibiotic. Okay, there are a lot of studies conducted in India throughout the India using this SP standardized method, and they have seen that over-the-counter antibiotic dispensing. Okay, you will see a detail about the findings in the coming slides. So what application of SP? You can see here, wherever the prescription audits are not possible. As I mentioned earlier, getting the quantifying or the counter antibiotic dispensing. Okay, that means antibiotic audit is not possible. So SP studies has been used to see pharmacy practices like the dispensing practices. So SP methodology is considered as a, this is very, very important. This method is considered as a gold standard method to assess the provider practice. For example, the pharmacist is a provider, the practice is actually dispensing of the medication. So this methodology successfully applied to provide the insight on how the pharmacists manage the cases of TB, upper respiratory tract infection for the adult patients, and even the pediatric diarrhea. All these areas already studies have done using the SPs. So what SP studies have found that 14% of SP visit involved in the provision of non-prescription antibiotic. That means over-the-counter antibiotic Okay, prevalence is around 15 to 40%. Okay, through the various SP studies are reported in the different part of the country. So we thought that why we can't do one study, okay, or using the SP study. So we have conducted this study in our locality, that is UDP. So we have conducted over-the-counter antibiotic dispensing by pharmacy using a standardized patient method. So it was published in 2019 in the BMJ Global Health. So this study was actually funded by McGill University, Canada. So because of that, whenever the pharmacists are, when we have recruited 3 SPs, okay, 3 SPs from the locally, those who know the local language, and we have trained them to act like a SPs, and they went to the pharmacy and asked for the medication. So whenever the pharmacists are dispensing the antibiotic or any other drug, so they will purchase and come back. Okay, because we are actually funded by our project is funded by McGill University. So objective of this study was to assess overall non-prescription OTC antibiotic dispensing by private community retail pharmacies. For the we have created for 2 scenario, adult and children. Okay, for 3 disease conditions we have selected case scenario, 3 case scenario. One is for the upper respiratory tract infection. Second one is acute uncomplicated diarrhea. Third one is a fever suggestive of malaria. These are the case scenario. So for these 3 case scenario, we have developed adult case and child case. Okay. So one more thing we have to remember. Okay, we are recruited only 3 adult SP. There is no children is recruited as a SP. So you will only the adult the SPs will go and present the pediatric scenario. Okay, we will see. I will show you how the case scenario is developed. Then you will realize that. So this was the primary objective. Secondary objectives were to examine how this outcome means over-the-counter antibiotic dispensing differed between the adult and children, and to determine which factors of SP visit were associated with antibiotic dispensing. Okay, you can see here the factors what we have considered: the history taken by the pharmacy, the client volume at the time of visit, whether the SP was referred to the another provider, and appropriate time spent at the pharmacy and pharmacy location, either urban or rural. So earlier I told that the case scenario what we have developed. So the SP case scenario for both adult and children with expected outcome. So already I told that there are 3 cases. One is for the upper respiratory tract infection, likely of viral etiology. Another one is uncomplicated acute diarrhea. Third one is acute febrile illness suggestive of malaria. So second column represents the symptom. For example, upper respiratory tract infection. So what symptom the SP will go and present? Individual with 2-day history of acute onset, low-grade fever with a runny nose and non-productive cough. Does not look sick. The family members have the similar symptom. The opening statement by SP on entering the pharmacy. When SP is entering to the pharmacy, what you will tell to the pharmacist? Okay, you can see that already I told there is a 2 child scenario and adult. So the SP acting like a for the child scenario, you will, while entering to the pharmacy, you will tell for child with the upper respiratory tract infection. Sir or madam, my niece at home has fever and cough. Can you give me some medication for her? Whereas the adult with upper respiratory tract infection, since 2 days I have cough and fever, can you help me? Okay, so there are some acceptable management and some are unacceptable management. What is acceptable management? No dispensing antibiotics with or without referral to a doctor. Then dispensing symptomatic treatment according to current guidelines is acceptable. Whereas unacceptable is dispensing antibiotic or steroid. That is unacceptable. Then you can see uncomplicated acute diarrhea. So here it is individual with 1-day history of acute onset watery diarrhea, no blood in the stool, no fever, appearance of well hydrated. So child with diarrhea, so what SPs will tell when they are entering to the pharmacy: sir and madam, my niece at home as diarrhea. Can you give me some medication for her? Whereas adult with diarrhea, I have diarrhea, can you help me? So acceptable response, dispensing ORS, oral rehydration salt, and not dispensing antibiotic with or without the referral to the doctor. And for pediatric SP, the thing should be given along with the ORS, because already it is proven that it can rapidly cause the recovery. It will reduce the episodes and severity of the diarrhea. Unacceptable one is dispensing antibiotics or restricted anti-mobility drugs such as loperamide. That is unacceptable. Okay, so these are the acceptable response and unacceptable response. Then acute febrile illness suggestive of malaria. For that, individual with 4-day history of high fever with shivering, chills every other day, and no cough or other symptoms. Okay, no headache, fits, or altered consciousness. So, child with fever, sir or madam, since 4 days my niece have fever or chills, can you give me some medication for him? The adult with fever, I have fever since a few days, that is not going away. I am also get ill. So what is acceptable? Referral for the malarial blood test without dispensing anti-malarial or antibiotics. Whereas unacceptable, dispensing anti-malarial or other antibiotic or steroid. So whenever you do the studies, SP studies mainly, so that developing this case scenario, the time and care where you have to spend is developing the case. Okay. Whether your this case scenario will be able to capture the data what you have required of or not. For that, okay, you should develop a very carefully the case scenario while doing the SP studies. So what are the key findings of our study? Already I mentioned that it is done in the Udupi district, Karnataka. We completed 1,522 the pharmacy SP interaction for the 3 conditions: upper respiratory tract infection and then diarrhea and fever. Okay, for the both adult and child scenario. Okay, so our study found that only 4% of pharmacies provided the over-the-counter antibiotics. Okay, when you are splitting into the adult and pediatric, you can see here antibiotic were dispensed 4.34% of adult interaction, but whereas 2.89% of pediatric interactions. Then antibiotic dispensing was highest when the pharmacist asked more questions or spent more time with the SP, and lowest when they referred SPs to the another provider. Okay. Another key finding is despite the low rate of antibiotic, we have seen only 4% overall. If you see, only 4% of dispensing. Okay. Despite low rate of antibiotic dispensing, okay, the case management by pharmacist was still poor as evaluated by adherence to the international guidelines. Why it is case management was poor, we are telling, because they are not given, some pharmacies are not given antibiotic, but they are given some unnecessary medication. Non-antibiotic for the symptomatic treatment, some drugs they have given. Then case history taking is actually poor. Okay, that's the reason we are told that case management by the pharmacist was poor. So this was one of the study. Then this study was conducted in the before COVID. Okay, it was published in the before 2019. Okay, during the COVID, we have seen that okay, there are a lot of antibiotic use is increased. The sales of antibiotic, especially azithromycin sale, is increased during the COVID. So then we thought that why can't we do another study? Okay, earlier we are develop a case scenario and ask for the medication. We are not asked for the antibiotic also. We just ask for the some medication. Okay, so whether they are giving especially antibiotic or not, that was our first case. But later on, during the COVID, as I mentioned, you can see that there are a lot of antibiotic sale is increased, especially azithromycin. Then we develop another protocol to do a SP. In that, what we have focused is the SPs will go and ask the medication directly. For example, azithromycin. So we have look in Indian scenario, you can see nobody will go and ask azithromycin. There's some brand they will go and ask. So we look into the which is a very commonly available brand. So we found that ASI, AZEE, ASI 500. So here you can see that this I was given for the PharmD project. So PharmD, the students, 5 students, they have went to the various pharmacies, around 150 pharmacies, and they directly asked the half course of that to take some upper respiratory tract infection like synovitis or even for bronchitis, lower respiratory tract infection, okay, respiratory infection, normally 3 to 5 days they have to take. But here they will go and ask for just 2 tablets of azithromycin. So this study, you can see that exorbitant use of over-the-counter use of azithromycin in a community pharmacy settings during the peri-COVID era by using a standardized patient method. So it is under review in the research in social and administrative pharmacy. So I will just present what was the summary of this study. I'm not going to the details of how we are carried out. So you can see here that between November 2021 to 22 June, so 5 trained pharmacy students was actually acted like a standardized patient, and they have visited 150 community pharmacies. You can see here each SP directly requested a half course, just 2 tablets of azithromycin, and interaction were recorded within 30 minutes. So what we found that of these 145, out of 150, 145 pharmacies, that means around 96.6% of pharmacies dispensed azithromycin 500 without the prescription. Only 8 pharmacies questioned the dose necessities. In that, even though they questioned, still they have given, some of them have given the azithromycin. 77% were ready to dispense half course without any inquiry, while 23 insisted on completing the full course. Okay, so what we have seen that over-the-counter antibiotic dispensing is 96.6% when we are actually going and asking the drug name directly. So already I mentioned about the SP studies. There are different SP studies already conducted in the different area. So some of the SP studies, this is not our study. So these are some other people have conducted SP studies in the different area, especially the TB. You can see here the variation in the quality of tuberculosis care in urban India, a cross-sectional standardized patient study in 2 cities. So it is conducted in the, one is in Pune, one is in Mumbai. Okay, so this article is published in the PLOS Medicine Journal. Similarly, another study was use of standardized patient to assess gender difference in the quality of tuberculosis care in urban India. A 2 city, a cross-sectional study they have conducted. So once you have done the study, what is next? Dissemination of research findings. So either through the publication, what we have already told, and conference presentation. So always you have to motivate your PharmD students or MPharm students importance of publications. So these are some of my PharmD students, those who have published their project. So why I want to emphasize, because of this publication, some of them got the postdoc and PhD also in the foreign universities. So the always encourage the students to participate the conferences in your the specialist domain. Okay, instead of, rather than attending all the conference, it is better to specialize like clinical pharmacy or those who are interested in some pharmacokinetics area. So there are different conferences are out there. So that let them present their findings in the various conferences, and even always try to be a member in one or another societies that is directly related to our profession. So some of the society you can see here. One is International Society of Pharmacoepidemiology. So it is one of the very good society. Why? Because they are conducting annual conference and even Asia specific conferences every year, and even European conference also. So there is high chance that they getting the scholarship Okay, sometimes if you are lucky enough, you will get the full scholarship or at least the registration scholarship you will get. So every year from our department, a large volume of students are attending. The last year, so this much students has attended the. You can see that the what we can say it was conducted in the Tokyo, Japan. So it's Asia Conference on Pharmacoepidemiology. I think some of your faculty also I have met there. Mr. Raghava, so I have met during this conference at the Tokyo. Another society is International Society for Pharmacoepidemiology and Outcome Research. So their scholarship is very limited, but if you are able to get some government scholarship, like you can see through the ICMR or even DHR, the travel grant, so you can apply that also. Whenever you are getting some partial scholarship also, there's a scope to apply the government travel scholarship. So you can combine all these things and you can make it possible your conference. So they also have the annual conferences. So another society is actually International Society for Infectious Disease. Those who are working in this area, even they have the every year they will call for the small research grant. It will be somewhere around 8 lakhs. Okay, you can see last year application deadline was March 15th. And the well-known society is FIP, International Pharmaceutical Federation. Even the name is FIP, it is called International Pharmaceutical Federation. They have the World Congress of Pharmacy and Pharmaceutical Sciences every year. Last year it was happened in the Cape Town, 2024. So the FIP have one program called Pharma Bridge. Okay, so you can, those who are working in the clinical pharmacy area, you can go and underwent training. Okay, at least 1 month training in the abroad. Okay, like I was lucky enough to get this Pharma Bridge fellowship, and 1 month I was there in the Canada, one of the hospital called CHIO, Children Hospital, Eastern Ontario. So the clinical pharmacy rotation, I was able to participate this through this Pharma Bridge training program. So those who are interested, you can go to this website and you can upload your CV, and there is a form you have to fill the purpose, all these things you can purpose based upon the your chance. You can see that there are a lot of people already registered for this. So once your notice come, so you will get some training abroad. The other society, Society of Infectious Disease Pharmacist. So they have a small fellowship training program in the area of infectious diseases. So another society is actually those who are interested in the drug safety. We have International Society of Pharmacovigilance. ISOP is the short name. So they also have the annual conferences. Then apart from that, especially those who are in the PharmD students, internship students, they can do already. Our PCA is permitting them to go for internship is 3 months. Either abroad also they can go, or even India also, within the India also they can. We have already have some MOU with some Australian universities, and Australian government have one scholarship called Chengong exchange program. It is a short term, maximum is 3 months. So some of the every year 3 to 4 students they will go during the internship, and they will do their partial internship in this. We have some of the Australian universities such as Griffith University, and even other universities in the Melbourne also we have the scholarship. Partnership. So some of our students will go to the Sydney University. Last year, these 4 students are actually went to the Sydney University, and they have done the internship over there. So this is actually what are the scholarship I have told. This is a government, Australian government Chengong exchange program. The purpose of this Chengong program is to support Australian universities to offer short-term mobility scholarship opportunity for outbound Australian students and inbound Asian students. So Australian students can go to the respective universities in India or Asia. Similar way, Asian students can go to the Australian universities and do the short-term training program. And apart from that, even within the India also we have the various internship program. For example, National Institute of Research in Tuberculosis, the ICMR Institute. So they have it's located located in the Chennai. So they have the internship program in the area of bacteriology, biochemistry, bioinformatics, clinical pharmacology. It is available, health economics, and immunology, and even public health and epidemiology. So especially public health and epidemiology, bioinformatics, clinical pharmacology, these are health economics, all these are relevant for us also during the internship in these institutes. Another ICMR institute is actually ICMR Health Communication Internship Training Program. So they will call for 3 months, okay, the internship programs. Some of our students have done, the ICMR have the institute in the Pondicherry. Some of our students have done. This is a paid internship. During the internship, they will get paid. And final, the certification will be awarded in the Delhi. So all these things will be covering by ICMR Health Communication Internship Program. Even some of the states also have some health and science and technology councils. For example, Karnataka State have Council for Science and Technology. They are funding for the students project. Okay, you can apply for this students project in that. They have the small grant funding for the students program. And even Kerala State also, they have the Kerala State Science, Technology and Environment. They also have the funding for the institute, the students project, get a small amount, the students project they will fund. Even I think every state have their own the funding mechanism for the students, but it is highly competitive because this is not only restricted to pharmacy or medicine. Anyone in the field of science or even technology can apply, so it will be highly competitive. Even some of this internship can be done in the pharmaceutical companies also. For example, Novartis. Okay, so they have the interview and various steps, aptitude test, everything if you passing through. So that you can do your internship in the companies. So once you've done the internship in the companies, it will be very easy to get absorbed. Okay, instead of directly applying, once you through the intern, if you perform very well, there's high chance that you will be get absorbed after your course. Then for this end of the last slide of my presentation. Okay, challenges of research. So this is also very personalized thing. Okay, one is actually role related. So what are the challenges for the students level? It will be totally different from the what we can say from guide challenges. Okay, maybe for the guide or the teacher's point of view, the challenge will be acquiring the fund. Okay, but students getting the what means the good group. Okay, or actually the good understanding between the group, those who are selected the same project. Okay, then setting related. Okay, our settings you can see that we have some challenges, like you can see that we have a lot of patient load. We will get all kind of patients, but only the problem our IEC, Institutional Ethical Committee, we had to get from our hospital ethical committee, Kasturba Hospital Ethical Committee. So it is very, very stringent. Okay, we cannot. It is not easy. Some of the time, not every time. Some of the time, the understanding them our concept. Okay, sometimes there will be some studies. For example, SP study, we need to get the waiver of consent. Waiver of consent means we cannot inform the pharmacy or we cannot get the consent form signed by the pharmacy when we are doing the SP studies. So if the IEC does not know about the SP studies, they will not provide the waiver of consent. Any study before that, we have to get the waiver of consent. But the thing is that our ICMR, the biomedical research ethical guidelines, it is clearly mentioned that which are the conditions we can go for the waiver of consent. Okay, so our SP studies is exactly falling into that criteria. So obviously they had to give, IEC should give the waiver of consent. So it is very, very sometimes a huge task to convince our IEC. Okay, that is a setting related. Different setting have different problems. Sometimes we may not have the sufficient load of patient. Then team related. Team related, already I told that sometimes, especially the students group project, one person will be overworking, other person not at all working. So there will be an imbalance between the group. Okay, all this will be there. So I just put the dots because different people have the different challenges. So what are the top challenges usually in all the research? I just put here. So I want to stop my presentation with another quote. If you are not willing to learn, no one can help you. If you are determined to learn, no one can stop you. So if you have any questions, you can ask to me. Otherwise, if you can even mail, I have just put my email ID here.
Thank you so much for the session, sir.
Okay.
At the outset, I sincerely apologize for not reading out your introduction at the start of the session. I'm extremely
That's okay.
sorry. Situation got confused. Situation got a little tensed up, so I directly hand over you the platform. So once again, sincere apologies. Please don't mind. And to rectify that, I would like to introduce this. I would like to briefly tell about the speaker to the audience. Dr. Sonal Sekhar is currently the associate professor and also the coordinator for Center for Public Health Pharmacy at Department of Pharmacy Practice, Manipal College of Pharmaceutical Sciences, Manipal Academy of Higher Education. So sir had his BPharm degree from the prestigious JSS College of Mysore and also completed his masters in pharmacy at VIPS Bangalore in the year 2006. He also has a PhD from Manipal Academy of Higher Education in the year 2016, and he has been serving his role in the academy, and very less is needed to describe his active involvement in research, because all the audience who saw the session saw his commitment towards his research in various forms, either in the community setting or either in the practical setting, in the clinical setting. So that was our speaker. And once again, sincere apologies, sir. Please don't mind.
No problem.
And I would like to see for any questions that were given in the chat box. Before that, I would like to ask one question to you, sir. So you were mentioning about the community projects that were carried out.
Yeah.
And do you think is it really essential to get an ethics committee approval for the projects that we conduct in community settings?
Yeah. So any study, if you are affiliated to one institute, you are accountable. So it is that usually it is depends. For example, our setting already I told our IEC Institutional Ethical Committee. It is very stringent. So any study if you conducted, you have to get the IEC.
So even if it is a community project,
yeah,
you still
community
get the
project also you have to get the IEC.
Okay, so for a community project, you still get the IUC from the institution where
Your
you are
institutional
registered.
ethical committee. But community project, sometimes what will happen, even there will be a community, if you are going to the some community project, that depends. Sometimes you are doing the patients you are doing. Sometimes general population you will be doing. Sometimes community studies you are conducting in the pharmacies. Sometimes you can even do the community study in the clinics. For example, you are doing some community studies in the primary healthcare settings, right? If I'm doing a study in the primary healthcare center, so it is a government institutes and primary healthcare centers, BSc primary healthcare center. So if I'm applying in my IEC, so they will tell that you have to get the permission from the district medical officer.
Okay.
So I had to give a letter of permission I had to get the letter of permission from the district medical officer when I am applying for the IEC in our institute.
Okay.
Because who are actually the authority of that community has to certify that this study is permitted to do.
Okay.
So that all depends upon how stringent your IEC institutional ethical committee. So that's what I told that in the challenges. So one of the challenges is setting related. Okay, if our IEC is very stringent, okay, you cannot you have to go through all these process. Sometimes they may not be very much stringent, or sometimes the reviewer, IEC reviewer also keep on changing, right? Sometimes it may not be going to same reviewer. So different reviewers have different opinion. So sometimes you will be passing through. It is like even a survey study also, the online survey also for us to get the IEC. But the forms for the survey study, forms for the cross-sectional study, the forms for the intervention study, everything is a little different. So based upon that, there will be a leniency will be there. If we are going for a retrospective study, a little more lenient when they are doing the review rather than the one intervention study. When you are going for an intervention study, it will be little more scrutinized.
Okay.
So any study, you are actually pay whether the patient involved or participants are involved. Okay, you have to get the IEC because there is a participant. Your study can be directly or indirectly affect the participant. That's the reason the IEC is required, not just for the patient. Even the if you are if you are educating one common people in a society, so you are giving an education intervention there. Sometimes your IEC has to go through that what intervention you are going to provide, whether it is actually harming that normal people or making some kind of unwanted, you are giving some unwanted information to them. All this somebody has to scrutinize, right? So that's the purpose of the IEC.
Okay. I got it, sir.
There should be accountability should be there. So that's the reason IEC is working, not just because patients are involved, IEC should be there. Otherwise, no patient study means, sir, earlier we also thought, but once you are started reading the ethics or biomedical ethics, your concept will change. Why there should be IEC? It is actually giving some accountability for our study.
Okay. As a continuation to this, sir, institutes like Manipal and JSS, where they have their home hospital where they carry out a research. So these hospitals will already be having some form of IEC so that they can directly apply their PharmD or pharmacy practice projects directly to the institutional ethical committee. So any suggestion or anything that you want to tell to those institutes which are not having their parent hospital, but they are getting their internship done in different hospitals. So what suggestion do you want to tell to those people where they can get that IEC from?
Yeah, so if those hospital, you get to see that whether that hospital have IEC or not. For example, you are doing some MOU, MOU with some other hospital where your students are doing the internship or project. That hospital may have the IEC, right?
Majority of the times, yes.
In case if it is not there, what you can do, the college level, you can constitute one IEC and try to put that clinician also from that hospital as a member, and you can conduct. It is better to register in the ICMR and DHR. There is that is better to register always. Then you can conduct the IEC for your students. That is all the option you can do. But it is should be always any study. It is better to take the ethical committee clearance.
Yes, sir. And there is a question from one of the participant.
Because one more thing, one more thing. Our any prospective study, whether it's not even a clinical trial or intervention study, our IEC even tell we have to take the CTRA, Clinical Trial Registry of India. If it is a prospective study, it is not at all mandatory that it should be actually a intervention study or trial. All the prospective studies should be registered to CTRA. That was our IEC. So when we are applying for CTRA, Clinical Trial Registry, so one of the thing what we had to upload the IEC certificate. Okay, when you are uploading your CTRA, so our IEC certificate also we have to upload. So obviously you have to take the IEC certificate. I mean IEC clearance.
Okay, sir. And there is a question from one of our participant, Dr. Sanat Kumar. He says, is it mandatory to have an MOU to have fellowships or training program outside the country?
Most of the time it is mandatory, but there is an open call. Wherever the open call is there, so that case there is no mandatory. Open calls fellowship, there is no need of any MOU. But otherwise, like you can see Chengong fellowship, what I told. So we have MOU with some of the because Chengong scholarship is given by Australian University, Australian government. Chengong scholarship is given by Australian government. But there could have MOU with some of the Australian universities. You can go to that particular Australian university. So, but there are some open calls also will be there, fellowship. For example, I have told that International Society of Infectious Disease Pharmacists, their fellowship, that society is offering the fellowship. So there is no need of any MOU. You can directly apply and get.
Okay, sir. Okay, then, so these were the questions that we have for you, sir. So
Okay.
once again, on behalf of our institute, on behalf of Department of Pharmacy Practice of our institute, we once again thank you for accepting our invitation and taking the time out of your schedule for making this session happen today with us. We are very, very happy to have you, and I think all of our participants got their time's worth by listening to your presentation. Thank you once again, sir.
Thank you once again for the institute and even management also. Thank you so much.
So thank you, delegates, for joining here with us today on this platform. Tomorrow, we'll start another session with another speaker at 11 a.m. in the morning. Thank you, and we all leave the session now.